Hi, Andrew with Heavenly Smiles, and today I have joined Crispin Simmons here in Seattle, who was so gracious to grant me an interview with him. I would love for you to meet him and hear what he has to say. He's a cranial facial pain specialist, is
Correct.
what I'd like to say.
Correct.
He's works with orthodontia in a special way that he has found to work in a very unique way that helps people, and of which I got to be blessed having treatment with him for a couple years. So I just want to introduce you to him and let you know that he's not just an orthodontist or even a TMD specialist. He to me is the best that's out there that I have found. And the results that I had, I'll share with you guys later. But for right now, I'd like to introduce you to Crispin Simmons and have him just share with you what he does and what a master he is at helping people get out of pain, truly. So maybe you could start with just why a lot of people do come and see you and what brings them to Seattle to see a specialist. Are they in pain, or are they just wanting the best treatment that they've heard is out there?
Well, craniofacial pain is a relatively new specialty in dentistry, so most people are not even aware that there is a specialty. It's previously been treated by primarily general dentists. Have treated these patients suffering from craniofacial pain or temporal mandibular disorders, as it's also known, or um, pain and sleep problems occurring other than with your teeth itself. So everybody is familiar with a toothache, may have never had one, but they have an idea what a toothache pain is. So oftentimes these pain issues around the jaws, the upper and lower jaws and the jaw joints, mimic toothaches and other kinds of dental conditions. So the specialist's job is to discriminate exactly what is the patient's problem. And so, having said that, we can talk a bit more about that in a little bit. But why do patients seek treatment? Well, the one reason why patients seek treatment from someone like myself is because they're looking to reduce their pain. So, well, what kind of pain is that? Well, it's headache pain dominates the field. Most headaches are caused actually by muscle tension disorders in the jaws and neck. And so you have preferred pain patterns as well as direct pain at a local site, as if you could touch it, you could feel the pain there. Other pains occur in various areas of your face or inside your mouth. The pain is referred from another area. So the actual problem exists elsewhere at some distance, sometimes the neck, sometimes the jaw, sometimes a head pain here, where the pain is here is actually that area is not actually painful, but it refers pain to the front of the head, for example. And there are many of these pain patterns. We're not here to teach you a course in this, just to give you some information to help you discriminate what you or your friends or family may experience and who they might decide to seek to treat them and why. So pain is the main driver of patients here. We see some patients here because of sleep disorders, so we also treat them dentally, which is primarily a dental sleep appliance. This is what dentists are licensed to deal with. They're not sleep physicians, so they have to work within the boundaries of sleep medicine. So that means they have to include a sleep physician in your care if that's a decision that's made. Sleep appliances. Uh, so typically, one of the things that keeps people away from treatment, in my experience, is that they think they have a jaw joint problem or they have some problem with their teeth or jaws that's going to require them to have surgery. And of course, surgery is nothing any of us want, and most of us will avoid any surgery. And I know for a fact that there are many people that don't seek care because they think the answer is going to be surgery. And they've already decided that's not going to work for them. So you should know, and I always tell my patients that are here for consultations, on the front end of it, I cover that topic right away, that these problems rarely require surgery. There are some indications, of course, for surgery, and we're glad that we have those technologies available, but it's rarely indicated.
Yeah.
So if surgery has been recommended for you as a result of one of these, I highly recommend that you seek a second and or third opinion. Understand clearly what the surgery is attempting to do and what the after surgery problems may be. So oftentimes people believe that surgery will resolve their problem, and that's the end of it, and they'll never have a problem again, like removing your appendix. Nobody gets appendicitis after they have their appendix removed, right? But that doesn't work in the case of jaw dysfunction disorders. Often leads to more complicated problems, requiring a lot more money, time, and energy to treat with reducing positive outcomes. So, having said that, patients come from different age groups, different sexes. There's no predominance. There used to be believed that these problems dominated in women, say 35 to 45. It's not been shown to be true. There have been many studies done all over the world in various age groups. It used to be thought that, as you got older, your jaw problems just went away. The joint popping, clicking, limited open, pain, all those things would go away if you lived long enough. And it is true that if you die with the problem, it's gone. The problem doesn't exist anymore.
Right.
But that's not what we want. What we want is to restore our quality of life and keep a healthy jaw function for our life, because it's so important for our general health. Most people are aware these days of sleep apnea issues. These are often also correlated with temporal mandibular disorders. They often occur simultaneously. And you ask why? Well, my opinion is that they both have the same fundamental cause. And the cause is a distortion in the growth of the upper lower jaws and the airway. And this is the ultimate cause of these problems. Also, the ultimate cause of orthodontic problems, as a rule. So most people have crowding, have narrow arches, overbites, or things that are generally noted and treated orthodontically, are related to dysfunction of the growth and development early on, the failure of the child to grow properly from a young age. Begins probably about a year and a half old. It starts, although we don't treat children a year and a half old orthodontically, of course. But for young toddlers up, there are treatments, various myofunctional therapy treatments that we now have that are very effective and very easy to administer to a child to help this.
Yeah.
So it's important to guide these children through several years of treatment. It may not be, it's not going to be aggressive treatment. It'll be easy treatment at home. So these treatments are designed to improve the growth of the child. And they're very safe to use. You cannot overgrow a child, upper lower jaws, not possible to do. So, and there's obviously no surgery, and for much of that time, very little fixed appliances, if any, are necessary.
Just myofunctional therapy.
Yeah, can be. There are every kind of treatment that's available out there. And there are many good ones, but every one has some shortcomings. There's no treatment that we can magically do to people that change things without some kind of intervention. Often it's a cooperation factor from the child or the family. It's not all on the same page, so the children don't get monitored well at home between appointments. Sometimes it's just the wrong time for the child.
Yeah.
They have to. Every patient is a different patient, obviously, and they have to be managed differently. But keep in mind that whether you're an adult having a problem now, if you have children, you need to understand that your children not because it's a genetic problem as a rule, not passed down genetically,
Mhm.
but passed down behaviorally from in the family. So people will say, "Oh, my father had this dental problem. My father had this orthodontic problem, crowded teeth, or excessive overjet in the front." Uh, those were problems that, by and large, could have been intercepted
Mhm.
in a child.
Yeah.
But that's not to say that everything wasn't done that could be done historically. But things are changing. Information is changing. The methods that we have to treat people, those are changing, becoming much more patient friendly, if you will. But still require you going to see a properly trained
Hmm.
dentist as a rule
Yeah.
in these ways. Yeah.
And when I was in Texas at your conference, a lot of the people that were speaking raved about your sleep appliance because you do a sleep appliance in a way that balances out the jaw so that people are not just having their airway open, but they're also not creating pressure with a sleep appliance that could create damage to the TMJ or pain.
Correct. Well, in the case of sleep, just making a sleep appliance, in my opinion, just fabricating a sleep appliance for someone is not a total treatment, or let's say, is not predicated by a thorough diagnosis. Now, hopefully, and absolutely should be, a sleep physician involved in that process.
Okay.
They make the sleep diagnosis. Dentists do not, but dentists do make oral appliances that can modify the airway and correct the sleep apnea when they're worn. That, in my opinion, requires more than what is being done routinely now in dental offices.
Yeah.
Routinely in dental offices, they make impressions of your teeth, and they may or may not take an actual bite registration of your teeth. They make impressions of your teeth, and those are sent to a laboratory, and a sleep appliance is fabricated. Now, there are well over 100 sleep appliances out in the world being used.
Okay.
They all only have one real capability, and that is, when you close into this appliance, your lower jaw has to move into a non-tooth together position, into a postured position to bite into the appliance to support the jaw in that position.
Okay.
So that's what they all do. No matter what any dentist says, they all just reposition your mandible and thereby open the airway by pulling all the soft tissues in your throat, of the forward part of your throat, forward. And that opens the tube back here.
Yeah.
Now, if you have nasal congestive problems, those should be corrected. It's not about helping the patient breathe through their mouth. We don't want people to breathe through their mouth. That's not a normal human condition, to breathe through your mouth. That's not healthy. And you will die earlier, probably.
Yeah,
for a variety of things when you're breathing through your mouth. You can't fight infections as well because you don't have the nitric oxide exposure that you get as air passing through your nose. If it passes through your mouth, you don't get that.
Yeah.
So it's important to know what's going on in this whole system with regard to the airway. And if you need to have these things adjusted, and we commonly find patients with nasal obstructions.
Mhm.
Well, a dentist can't really do much about nasal obstructions. Not in an adult, for sure. In a child, you have some opportunity to gently change that. But in adults, you need to employ the expertise of ear, nose, and throat physicians who can go in and modify your nasal airway.
Mhm.
A lot of people have obstructions there because of crooked septums or enlarged turbinates inside their nose. Some adults even have residual adenoids, or usually adenoid tissue at adult age. Because of their inability to breathe through the nose, the adenoid tissue actually enlarges over time because of that.
Yeah.
And in children, sometimes the tonsils and adenoids need to be removed. In other words, the goal should be, first of all, in a sleep issue, maximize breathing through the nose. That needs to be corrected. And beyond that, if that's okay, then you have an obstruction here because of collapse of these tissues when you go to sleep. When you go to sleep, some stages of sleep, basically you become semi-paralyzed.
Mhm.
Some people have had the experience of sort of waking up, their brain
Mhm.
and their body's not yet awake.
Oh, wow.
There's like a little
Delay.
in there, like if you're having a dream or something and you wake up,
Yeah.
you kind of wake up and you realize, wait a minute, I'm not able to just like move real quick. I got to wake up my body. And so that's kind of what happens to you in your sleep. Those other muscle responses. So your muscles theoretically rest, your body relaxes, you're breathing, but that's a different level of activity. So it's important to be able to maintain that. So nighttime appliances are often required. Lots of patients come to us for sleep issues after CPAP. So they've been using CPAP, they've been diagnosed, been treated, they've been using CPAP, and for one reason or another, either it's incompatible for them, or they have difficulty maintaining the CPAP mask, or it creates another problem.
Okay.
I've had people with severe rashes. I've had people that have other intraoral problems, especially if the appliance is designed to help you breathe through your mouth.
Mm-hmm.
So breathing through your mouth, as you know, your hygienist, that increases your risk of decay and periodontal disease pretty significantly. That's not an airway. This is not an airway.
Correct.
Only when we absolutely have to breathe and cannot breathe through our nose
Yeah.
does this engage.
Yeah.
So we call that obligate breathing. Humans are obligate breathers. That means only breathe through their mouth when they're obligated to do so because they can't breathe normally through the nose.
Okay.
We jokingly tell our kid patients when we're working on it, this is a food hole. This is an air hole. You wouldn't put food up your nose, would you, Johnny? And they go, oh, no, that's silly. Yeah, I know, but why are you putting air here when it's supposed to be here?
That's good.
Well, that's because they can't. So we just try to help train them a little bit and wake up their mind a little bit in terms of their understanding of what's happening to them. Because children don't know.
Yes.
Most adults don't even know.
And I remember at one of your conferences, you summed it up really well with lip seal, tongue at the roof of the mouth, placed at the palate.
Correct.
That's the goal. And
Correct.
breathing through the nose.
Yes, we refer to those concepts as the big three, actually.
Yeah.
So what are the big three? Well, you need to have a airway that's open, or what we refer to as patent. You need to be able to breathe through that.
Okay.
Lips need to be together, not strained, but lightly touching, relaxed together. And the tongue needs to be positioned properly in the roof of the mouth in a proper way. So with these patients with sleep problems, we always see deficiencies in one or all three of those areas.
Yeah.
Also, most orthodontic patients, we see the same issues. And most patients with temporomandibular disorders, facial pain, we see those same issues. Not all of them. There are always exceptions to every rule, but definitely these conditions dominate. And the reason is, as I said earlier, they all have their origin in the same fundamental problem.
Yes.
The jaw can't function correctly if it's mal-oriented to the lower jaw is mal-related to the upper jaw.
Yeah, the upper jaws maybe didn't develop forward enough.
Didn't develop forward enough to allow the lower jaw to develop forward enough. The upper jaw didn't develop forward enough, so the pharyngeal area, the area where you breathe through here and where you swallow through, that did not develop in the proper dimensions.
And is that mostly because the tongue's not up there on the palate to push the upper arch forward? Is that why we see this so much? The tongues are down?
Well, it's a kind of an academic argument about, well, is it the chicken or the egg? What came first? And I think we have to go back and look historically at what humans are actually designed to do.
Yeah.
After several million years of evolution, there became human beings, and we were designed a certain way.
Yeah.
We're the only mammal that walks on 2 feet and upright. No other mammal does that. That means that our airway had to undergo significant modification to turn a corner rather than be straight like all other mammals are. Cows and monkeys, even, yes, monkeys sit upright and stand upright and walk along it. But their upright posture is not their full-time posture. They're always leaning over like this,
Yeah.
if you notice. in videos, nature videos of monkeys or gorillas or whatever. They have a leaned over posture. It's because they have a straight spine, straight neck, and the face is more forward than ours. Our face is down this way. Their face is more forward of the cranium. So those are developmental features that we can see historically in anthropology,
Yeah.
observing those things in biology. So when we were Aboriginals, true Aboriginals, living hunter-gatherer wise, we didn't live in structures. We had some of them had some movable structures, but we didn't live in structures full time. Most Aboriginals observed today do not sleep indoors often, only in very inclement weather. They sleep outdoors in the air, and they sleep on their back. And most people north of the 30th parallel can't do that. They sleep on their back. They're snoring and gasping. It's just not a good sleep position for them. But those people developed without any conditions that caused this to change its growth pattern. So what would be the most dramatic change that you would have? Well, the most dramatic change you would have would be congestion of the upper airway. So if you begin to develop allergies, or you're living indoors more in an enclosed space more, even though it may be a grass shack 10,000 years ago, or a fat shack or whatever, you had a lot of toxins in that area.
Versus being outside.
You had animals dwelling in the building materials itself. You had molds, you had animal feces, you had animal fur, you had insect feces and insect parts, which also causes allergic reactions. So we can surmise that was a big problem initially. And then, so the upper airway could not develop because the matrix, or the component that makes the upper airway develop correctly, including the upper jaw, we call this the nasal-respiratory complex, is air moving in and out of your nose.
Okay.
That's all it is. It's not an orthodontic wire. It's not a force. It's not a screw. It's none of those things. It's a gentle force, just like that you can barely feel.
Okay.
Propelling in and out of the nose. That's what the stimulation is for these areas to grow.
For the upper to grow
For the
forward.
upper to grow forward and wide and forward. So most we looked at 1,000 of our patients' databases, looked at their cranial formation patterns. Didn't matter what race they were, sex, didn't matter. We just took 1,000 random patients and looked to see if they had a shortage in the maxilla or not. And about 90% of them were short. We're short from where we know Aboriginals are, because we have those skulls as well. There's probably 25 or 30 at least Aboriginal groups still out in the wider world that don't live like we do.
Yeah.
The other factor was the change in food, which occurred worldwide, oddly, all over the entire world. And this was before the internet. All over the entire world, within about a 2,000 year period, people began to farm. And when they started farming, they needed to maintain and hold that property. So that meant they were no longer moving. We have evidence of, in the Middle East, of Aboriginal tribes living in the same close area to each other, but one is a farming community, the other is Aboriginal community. So we know they coexisted for a long time, and we still do. We don't see those people. We go to Eastern Washington, those people aren't in Eastern Washington. There's nobody like that around here anymore. We've all changed to this Western mode of living indoors, and then eating a very processed food. This is also a big thing. Currently, there's probably very little that you could find in a grocery store in a modern Western setting, or even in China or Japan or any of those areas. Anything north of the 30th parallel has become more developed. So we go to the grocery store and we look around in there, and we all kinds of good foods there. Much of it's not very nutritious. and hardly any of it requires chewing.
Right.
Most of it you could gum it really easily and get it down.
And that
Even a hamburger, you could tear off a piece of it,
Mhm.
stick it in your mouth. You don't have to bite it.
It's true.
You tear it off, put it in your mouth, wish around in there, and then people do that.
Yeah.
There are people without any teeth. They only wear their teeth to church.
Yeah.
The rest of the time they're living in a community where they're doing a job where it doesn't matter if they have teeth or not.
Yeah. Sure.
So I've had patients like that in my early career where they say, don't worry about this or that, doc. It's fine. I only wear my teeth to church on Sunday. But most of us want to have teeth all the time. So the actual chewing of hard, tough foods is also what stimulates the growth not only of the maxillary complex, but also the mandibular. In other words, the whole craniofacial complex is stimulated by that.
Yeah. So to review, the air coming through the nose, and then the foods that are harder, like apples and tougher meat, and
Correct.
that helps develop.
And then if you're not able to breathe through the nose properly, you're going to breathe through your mouth. If you breathe through your mouth, your tongue cannot be up in the roof of your mouth.
True.
Because that blocks your mouth airway.
Correct. Yeah.
But that's where the tongue's supposed to be. It's supposed to function up there during swallow and be up in the roof of the mouth during rest also. But that only occurs in my patient population. I see it maybe 10% of the time that it's actually in the right place.
Yes.
Having said they still have some other conditions, but not everything is wrong, right?
Right.
So that can be changed with myofunctional therapy and so forth, these other treatments, but they have to be done together. You've seen many of those kinds of patients where, well, we have to do something with myofunctional therapy here. We have to get the tongue up there. You can't just tell the patient to put their tongue up there. It's not going to happen. You can't tell them, well, don't breathe through your mouth anymore. You can't just tape their lips. If they don't have nasal patency,
right,
you can tape they're not going to put any tape on their lips because they literally can't breathe then. And so that doesn't work. So the strategies have to be properly organized. So chewing the food, and then we have the problem of breastfeeding.
Mm-hmm.
So in our more recent modern times, babies are not breastfed for 3 to 4 years, which is the normal human breastfeeding pattern.
Yeah.
Now, you're not just only breastfed to 3.5 years old, but these communities that still live like early primitive humans, they don't have, the women don't have babies every 2 years.
Right.
I mean, I have patients and family that, they have a new baby every year and a half. They got a new baby, they have a baby and they get pregnant really pretty soon after the first baby.
And then you can't nurse.
You can't nurse, and there's no time. So it's also a stress on our females in our population, having babies that in an increased frequency. It's just not. It's hard on the gals for sure.
It is,
It's hard on them. So a lot of things have changed, and the breastfeeding is part of that component as well. Not much of the dentist can help with that, although we do. It is more properly known now.
Yeah.
I was doing tongue-tied release 40 years ago in some patients because they needed it. Now it's a very common thing, and unfortunately what I'm seeing in the practice now in second opinions are people coming in who've been recommended a tongue-tie release when they don't have a tongue-tie.
Yeah.
They're not tongue-tied.
A second opinion.
And they've had, if they are marginally tongue-tied, they've had no myofunctional therapy prior to, because often that can correct the marginal case, just the myofunctional therapy itself. So you don't need to do surgery. But,
I was one of those people that, that you scanned me and said my airway was really open, but I do have to strengthen my tongue to have it be, because my palate's high.
Correct.
To have it be up there.
Correct. And just widening the palate, like I hear a lot these days about expansion. Patients are told, well, we need to expand your upper jaw or expand your dental arch or whatever. They're usually often not very specific about what exactly they are expanding.
Yeah.
Are you expanding the bones of relationships? Are you expanding the teeth within the bone? There are significant limitations to all that. And So it's important to understand what kind of expansion are we talking about and how is that going to be achieved.
Yes.
It's not a one trick pony. Expansion is not all expansion.
Well, and that's
and what are you trying to affect, and what is
Yeah.
the end result going to be? So
And that's what I find fascinating with you is I learned there is a lot of different ways of doing things, and a lot of doctors will just use one way on everyone, and that can create worst case scenarios where those people are in
Yes.
pain, and they usually because really I really enjoyed you treating me and allowing me to be here with you during the day and seeing patients who were in so much pain and nobody could help them, and they were referred to you, and they just would sing your praises that you got them out of pain when nobody could. And that's, to me, the biggest thing that I tell patients is if you have certain pain or ringing in the ears or deafness or vertigo, there are reasons that could be happening that people are unaware of which you can help, or you have helped people with that in the past because of how the pressure clenching and grinding and the you were explaining to me how this can get inflamed and pinch and create some of that problems, and you can get the jaw to be more balanced and relaxed with the machine that you have.
Helping to guide us,
Guide.
creating data for us to help us make good decisions about that.
Yes. And how you can help people there.
Yeah, well, it's a complicated subject, and that's why most dentists don't do anything with it. Some will dabble in it a little bit in TMJ problems, if you will. Even though the patient often does not have a temporomandibular joint problem at all, they have problems with the jaw muscles and posturing and other things. But that's why it's really important, and I teach this to all the doctors that come to visit me and want to learn something about what I know. One of the strong things I stress all through my presentations with them is that diagnosis is really 95% of your successfully treating your case.
Yes.
And you say, well, doc, that seems pretty high, 95%. So you mean you have to figure out what's wrong with the patient before you treat them?
Yeah.
Well, patients don't realize that that's a problem. I mean, for most people, they think, well, yeah, I'm sure that I want the doctor to figure out what's wrong with me exactly and then do something, and that's what they're going to do. Well, the fact is that that's less common than it should be. Way, way, way less common. Most patients I see are underdiagnosed and overtreated.
So they start treatment but don't really know.
They start treatment and they're not very specific about what they're treating. They don't know exactly. And that really reduces your success rate, especially as you said, if they have one trick, that everybody gets the same trick no matter what. Everybody gets the same prescription.
Yeah.
So usually though, the patient can figure out pretty quickly that whether what they're recommending is going to work or not. It should be dramatically improving them within the first 2 to 3 months, or they need to switch directions. Yeah. Or, as in my case of thinking, if the patient's not showing improvement quickly, certainly within the first 3 months, if I'm not seeing definite improvement, not only in the patient's complaints, but in the objective data that we can collect on their function and jaw movement, muscle function, and so forth, then I'm going back to review everything that I did to see what did I not see. What did I not consider? And there are always other things on the table, more unusual things, for example, that can cause jaw pain problems and dysfunction. Some of them the dentist can be effective with, and some of them we need to refer to other people to help us.
Right.
And that could include a long list of different types of physicians, and sometimes other oral surgeons to help when that's necessary. But the diagnosis is important. So that's one of my other cautionary tales. If you're going to see someone about your jaw function and they know what they're going to do for you, they have an appliance that they make for everybody, or they have a criteria that they use, everybody's the same. You have to be wary of that. You should experience a significant amount of time and effort being put into the diagnostic phase.
Yes.
So in our practice, that's about at least a 3-hour process, and maybe divided appointments,
Mhm.
but a 3-hour process of collecting and analyzing the data that we're going to use in the end
Yes.
to make a judgment. And then we have to redefine that each time the patient comes in, depending on how they're responding. But it's usually very effective.
Mhm.
So just keep that in mind. I see patients that have been treated for a year and a half and they come in
Mhm.
and with no improvement whatsoever.
Yeah.
And they just keep getting the same treatment and nothing ever happens.
So that's really good. They should see improvements within a few months, and if not, then we go
They
back to
need
the drawing board
they
and
need to
figure
look
out.
at something else, talk to their treating dentist, ask them about, okay, what other things do we need to look at or consider?
Yes.
Or maybe consider a referral.
And you did mention with me about kids, if kids have headaches when they're little, that's usually a sign it would probably be very wise of those parents to come and see you with that child and see if their jaw is creating the headaches, because most
It possibly
likely.
be creating headache. Yeah, I've
Little ones.
seen a lot of very young children with what would be diagnosed neurologically as a migraine type
Mhm.
headache. I've seen 6-year-olds that get up, go to school, and they're somewhat lackadaisical or don't seem to have a lot of energy. They're subdued. Sometimes they go to school and they throw up
Oh,
in mid morning. Maybe they had their breakfast or something. They get to school and they just have this headache. Well, children at that age don't know what a headache even is, especially if they've had it as long as they can remember.
true.
This is part of so I guess this is part of being a human.
Yeah.
Like I got 2 legs and they work this way, and I don't really think about it. My head hurts, but I just that's the way heads are, I guess. So that can be confusing diagnosis, and these children often end up, not that they may not need it for other medical conditions, but I've had children come in that are getting upper and lower GI examinations. They're looking at everything. They have files this thick,
Mhm.
and when what's wrong is their jaws are not growing properly.
Wow.
So they're having muscle dysfunction problems that are chronic,
Mhm.
almost muscle spasms, if you will.
Yeah.
Not truly muscle spasms, but very high increased muscle tension.
Yeah.
And so they're not able to rest their jaw muscles or muscles that surround their skull. So yeah, there's a lot of ways that these problems could be intercepted, and but part of the problem is the lack of training among dentists and physicians
Yeah.
about these problems.
And with children, do you start them off if they need myofunctional therapy, and then do you see if that solves it, and if it doesn't, if they need the appliance that you do for kids on the the bottom.
It's usually a combination of things,
Okay.
and they're usually stepped in some way. In other words, you can't just go in and affect everything all at once. For example, an appliance that stimulates growth is not an appliance that will necessarily stimulate widening of the upper arch.
Mhm.
So they have to be done in stages. Now, myofunctional therapy, for example, is a great therapy. We use it here. And it's absolutely essential to correct a lot of these problems, but it will not change the forward growth pattern. And that's really the deficiency. So a lot of focus is on expansion, as I mentioned earlier, which has a very minimal impact, truthfully, and high relapse over what's achieved. Most of those cases tend, no matter what the expansion was originally, they'll relapse down to about 2 millimeters ultimately.
Oh, wow.
And studies have shown that. So
it's not very much. Yeah.
It's not very much in the end.
Yes.
And sometimes I see patients that come in, I have their previous records, and they had expansion. They come in, there's no change.
Wow.
By the time I see them, there's no evident change there. It's all relapse back to where it was. So there's some issues about that. Again, I would stress, well, what are the main problems here? What's causing them now? And then this, with regard to changing tooth relationships and those kind of things, you don't start there just out of the box. That's not the whole answer.
Right.
The whole answer is more complex, and some other treatments have to be included, and they have to be included in a certain sequence for that patient, not for every patient.
Yeah. Everybody's unique. It sounds like to me, you don't have a bunch of cases that are all the same.
I don't have any case that's the same.
Yeah, so,
None
so
of them.
maybe if you have somebody who's doing the same thing on everybody, that could be a first red flag. Just get a second opinion, because it's complicated,
Right.
as you can hear with the way our skulls are growing now, and it's happening with little babies. They're born this way, and airway issues.
They
And
just continue to grow.
yes,
So seeking someone to help you, of course, that's a big problem. 'Cause people don't know where to go and find these people.
yeah,
I'm sorry, but I can't give you an answer of, if you call this 1-800 number, you'll get recommendation for doctors in your area that will take care of you.
Yeah.
Those are typically marketing kind of devices, and they have nothing to do with the actual doctor's skills.
yes,
These days, I think it's the best patients we have, the most informed or the most cooperative ones, have been referred here by their physician, their dentist, or friends or family members that have had similar
Treatment with you.
experiences as their other friend, and they say, you should go, at least go by there and talk to Dr. Simmons. And there may be somebody like me in your area. They're not everywhere.
Mhm.
There's probably less than 600 craniofacial pain specialists in the United States.
Wow.
Many of them have received their certification in the United States, but they don't practice here. They they come here for their training, they go back and go to other countries. So I'm not sure what the exact number of doctors that actually are available in the United States, but the point is quite obvious. They're not on every doorstep.
Yeah.
And many general dentists are very good at this. They've gone out of their way to get training. Not everybody's interested in the subject. If they're doing well in their practices, they're seeing lots of patients, they're doing the routine dental procedures, and they have enough of that to do. They're not interested in any of these specialty areas. They're not interested in orthodontics. They don't do periodontal surgery. A lot of dentists don't do implants. Another example in the growth of technology and knowledge is when I began doing dental implants in my general practice in 1981. That's what, 41 years ago now, something like that. And higher math at my age, you use higher math to figure out when you did what. But when I was doing dental implants back then, dental implants had a good history already. I was not an innovator in the dental implant world,
Right.
but almost no dentists were doing them. So we would have an organization that had a meeting every year at that time. It was originally it was a study club of dentists and dental implants in Alabama. Believe it or not.
Wow.
And just so happened there was just a group of dentists from Alabama who had gone and taken these courses. And then they connected other dentists from around the country. They came to the conferences. They need to take different courses with different people, learn how to do implants. They started doing implants. But it was very unusual. When I started doing implants in my town that I practiced in, at that time, it was a small town. There were 32 dentists. I was a heretic in the dental community.
Because you were doing
I was doing, that, and I was doing this type of work that we're talking about, all of which would be kind of heresy at that time, sort of dark magic or something.
Yeah.
You're putting pegs in people's jaws,
Right.
and shooting on them. Oh my God! And the oral surgeons at the time were absolutely opposed to dental implants.
Wow.
And I understand their view because the patients they saw with dental implants were patients who the implants were failing, and they need to be removed by an oral surgeon. The regular dentist didn't want to touch them because they didn't understand any of that.
Right.
So the only patients they saw were patients in implant failure, right?
Yes.
So they didn't want to touch them. Well, now, the story now is quite different. You just go on the internet in your town or whatever and look up dental implant dentist. And everybody's a super specialist in dental implants.
Yeah.
Of course, that's not true either, but you can certainly helps you with that search. Look for people who significant part of their practice is whether they're in general practice or periodontal practice or orthodontic practice is a significant part of their practice and training devoted to the areas of craniofacial pain, diagnosis and treatment.
With that.
Yeah,
Yes.
figure that out.
Mhm.
And then conversations with the doctor.
Mhm.
You know, so well, what is your training actually? How long you been treating these patients? So just have to be, the old caveat, buyer beware. Well,
Yeah.
patient has to beware, and I think we all know that now more than ever
Mhm.
with our medical care and our dental care as well.
Yeah.
We have to be our own sort of best advisor.
Yes.
And if you have weird, creepy feelings about a treatment suggestion, or just
Don't do
no
it.
harm,
Yeah.
don't do it. I tell all my patients to come here for consult. Look, if I do a diagnostic workup and you're not really comfortable with everything I'm saying, I have a lot of valuable information I've compiled for you.
Yes.
That's yours.
Yeah. You got to
And
take that.
Yeah, I want you to take that. Take that anybody you want to.
Yes.
And if you have questions later, call me and ask me. I now know what's wrong with you. I can now give you some advice via telephone,
Yes.
right?
Yes.
Because I've seen you, I've diagnosed you, I've evaluated you.
Mhm.
But that doesn't mean you need to come see me.
Correct.
You're always welcome to do that.
Mhm.
And I hope you get better, good treatment wherever you go. I'm just saying you do have to be vigilant about your own care. We have to do that in medicine.
Yeah.
We just have to.
Yeah. Second opinion, third opinion is very wise.
Absolutely.
And, more knowledge, I think, is best. And I had 3 different opinions, and you were the most thorough with when I came in and just all the workup you did, and then explaining to me for a half hour, like what I needed, what you thought you could do, or if I needed treatment or not, and let me decide if I wanted to. And I did feel like that information was mine, and it was so valuable to have. They may not know that you were one of the 6 people first to bring the 3D scan over.
What's called cone
Cone
beam
beam scan from
CT
Italy.
scan.
CT
that
scan.
A lot of people are more and more familiar with. Yeah, that was initiated by a study group that actually the study group has just ceased its
The one here in
operation.
Seattle.
No, it's our group in Sarasota, Florida.
Oh, okay.
Dr. Carl Gugino was our mentor there,
Mhm.
and I joined that group about 1983, 82 or 83,
Mhm.
through another connection with another study group
Mm-hmm.
that was meeting up in Tennessee at the time. So we would go there every 3 months, and we had to present cases and learn about new techniques of various kinds, including back then myofunctional therapy. We had a
Yes.
significant amount of training from a very highly renowned couple in California who did this. It wasn't even a thing back then, myofunctional training.
Yeah.
And myofunctional training was very difficult back then, very complicated. And so it never really found a place in dentistry because of that.
Yeah.
The newer myofunctional therapy systems, like MyoBrace, for example, have changed that
Mhm.
a lot, make it a lot simpler on the dentist as well as the patient, providing that service. But
Yeah.
the diagnosis process is still, you got to start there. You have to start there, and then the patient should be advised of all the findings, and in some, not minute detail, but in some detail, explain what are these findings, what do they actually mean,
Yeah.
and how does this jigsaw puzzle of my symptoms
Mhm.
that I'm having, which seem bizarre in a lot of cases.
Mhm.
You mentioned earlier some of the symptoms, and of course that's one of the things we have the patient check when they first come in to see us. What are your symptoms? And a lot of those symptoms that are on that list that they check, most patients would have no idea that, you mean this is well, I have this.
Mhm.
Like tinnitus, for example, ringing in your ears. Well, I've had this for years. Does this have anything? What does this have to do with your jobs? Well, it's not a complicated concept as what that has to do with your jaws. It's anatomically and neurologically known, and we know we can get good results in many of those patients.
Yeah. Because you were
But
saying
again, I don't treat tinnitus in patients who just come in with that complaint.
correct. Yeah.
They're going to go to the ENT. They're going to go be fully evaluated and make sure they have no other condition to be causing that.
Mhm.
And then they also have to have a diagnosable problem
Mhm.
or relationship that I can relate to that symptom. So there is a process. But when those things are clarified, our success rate has been about 95%
Yeah.
in
that's
treating
great.
tinnitus patients.
Yeah. And so what I hear you saying is that you will have a patient come in, you may refer them here or there, and you let them see that big picture.
Right.
It's not just you're going to fix everybody with a one system. You're the person that can, I like what you said when I met you. You said, I see the dots and I see how to connect them. And the dentist I worked for called you a genius, which, because,
Very kind.
well, it's really
I'm at least as smart as Einstein's brother. Let's say. I don't know.
well,
And I don't know how smart Einstein's brother was.
well, you look at teeth like, you do in dentistry. When you see a jaw, when you see an upper arch moving forward and you've never seen anybody expand the way you are expanding people's upper jaw when they need that,
Yeah.
that's very unique.
By stimulating growth.
Stimulating
Not
growth.
doing it by force, basically.
Yes.
Yeah.
And you guys, you kind of figured that out. Your friend who's a bone specialist in your conference, you mentioned
Right.
stimulating the bone around the upper teeth up here can actually get that upper jaw to move forward. And that is unique because there's not a lot of people
unique,
out
yeah.
there that do that.
Well, it's been and I have a lecture I've done several times on these concepts to introduce people to them. And it's been a known problem in dentistry since at least the first publication I have,
Mm-hmm.
and it's in my lecture, when there's a photograph in there of the dental appliance that they used in 1848.
Wow. Wow.
Yeah, actually, an actual reproduction of, I don't even know how they did it in 1848 exactly. Prior to that, it was woodcuts, wood blocks. They had to, if they had a print, an anatomical print, you had to carve it in wood first, and you made a print out of it. How they did that and made it so beautiful and so accurate, I don't know. But this is an actual reproduced photograph in a publication from 1848. And it was talking about expanding the arches, developing the arches, correcting them. So they've been attempting to do that since that time. In my lecture, I put up a photograph
Mm-hmm.
of a current appliance
that people are using
that's being used today.
Right now.
Any orthodontic dental laboratory you can order it from. And I asked people which one of those
is the one from
is
18.
the one from 1848, and which one of those is the one that you're aware of today? And they go, they look the same.
Wow.
Yeah, that's right.
Yeah.
Because except for some improvements in metallurgy and one thing and another,
Mm-hmm.
they are the same. They're the same appliance. So, and a lot of good people, a lot of smart people over the years in dentistry, they've worked on it because they know it's a problem.
Mm-hmm.
Edward Angle published his book, I think, in 1911. I'm not positive about that. I'm relying on my memory about that. But Edward Angle is known as the father of modern orthodontics. In other words, he was the first one to sit down and write an actual book and codify treatments and codify diagnosis in 1911. And in his book, he discusses this problem of maxillary development and suggests that, well, we don't know. There's a lot to be done here. He was always trying new appliances to see what they could do. There were severe limitations. So he acknowledged it. I think most people that bought his book probably cut those pages out, threw them away, and decided to ignore them, ignore that. But the point is, it's been something we've been working on for a long time. And myofunctional therapy is one of those things that does a great job with developing the arches.
Yes. I saw those pictures.
Does a great job with developing the arches. Yeah. And it's amazing. I mean, and if you look at the arches and the shape of the teeth, I also show some of these in some of my lectures where we only treated with myobrace.
Yes. It looks like they had braces.
That's all we did.
Yeah.
And it looks, they're perfect.
Mm-hmm.
The teeth.
Yes.
But you look at then the face and the skull, how they grow. Oh, they're still significantly deficient here. They look, sort of pushed in here, even though they have all their natural teeth. And so it depends on what you're looking for as a result. If your result is just straight teeth, that's what orthodontics does, and does a wonderful job of it.
Yes.
The Americans and the technology that Americans developed over the years is responsible for that improvement. But also on the sidelines there were these people, these sort of edgy dentists, out of the mainstream dentists, who were treating these kind of problems with what we would now call different types of myofunctional therapy.
Mm-hmm.
We're designing appliances that would alter the width and so on. And they were all hoping to also affect this. Doesn't happen.
Yeah.
So there's a whole different kind of biological fundamental phenomena that helps us with that. And the answers for that,
Yeah.
and the reason why it's not generally known in the medical and dental communities, is those answers and those statistics come from anthropology.
Okay. Where the mammals all have the same angles.
Study of the
Except for
mandibles and how they
us.
grow and why they grow that way and what are the influences. That's
Mhm.
all it was done in anthropology.
Mm-hmm.
And people who looked across that bridge between medicine and anthropology could see that.
That there was a change in humans.
Yeah, and there've
Yeah.
been books written about that. I have several of those books written about that. And these weren't nutty fringe people. They were good researchers. It just that bridge was not going to be crossed.
Yes. Because animals are going to keep doing what animals do, basically hunt and gather on the land. That's how they
That's what
eat.
they're going to do. And if their face doesn't grow properly, if they have a growth problem here, they're not surviving.
They die.
So we
Yeah.
don't. I asked an anthropologist once. I said, "Well, why don't we?
Yeah.
Do we ever see skulls of these animals that grew up and had these weird
Yeah.
tooth and jaw formations? No,
So
because they can't survive. They can't live.
well,
They die.
that's a good segue into how sleep apnea, you were explaining to me earlier today, just how it does create a shorter lifespan because of what sleep apnea can possibly do with heart and stroke and the
Right.
stress that it puts on the body.
Yeah,
Could
the
you-
list seems to be growing in terms of what
Yes.
publications I see.
Yeah.
The list is growing in terms of these relationships from cardiac disease
Mm-hmm.
and high blood pressure we mentioned earlier is common, and those lead to stroke, kidney failure, heart failure. The list goes on.
Yeah.
The various chronic diseases of the body that we all live with to some extent or the other.
Right.
Because of the society we live in, that we have more chronic diseases,
Yeah.
and we live longer with these chronic diseases now than ever before.
Yeah.
When I was a boy, I grew up with hundreds of people in our extended family.
Mhm.
We all lived in a relatively small area, a
Mhm.
few counties.
Mm-hmm.
And so we saw each other regularly, and we would have, reunions and Sunday get-togethers where there'd be 50, 60 people there. So I knew a lot of my extended relatives I knew growing up as a boy. And
Mm-hmm.
I remember there was a lot of talk with that many people. Somebody had always just died.
Oh, wow.
I mean, somebody in
Right.
the family, when we got together every month or something, somebody had died out of those hundreds of people. And I can remember something that kind of piqued my ears up when I was probably 8 years old, 7, 8, maybe 9 years old. I don't remember exactly. But I would hear about them talking about Uncle Bob or whatever. He might have been my great uncle, but he was out there somewhere.
Yeah.
And he died quietly, in his sleep. And I remember as a boy thinking, and this would happen,
Mhm.
this would come up.
Yeah.
If not every year, if not every few months, and certainly at least once
Once
a year.
a year.
This was kind of a recycling theme, and I thought, no. So you go to sleep in your bed quietly, and then you just don't wake up. So I can remember, I don't now have these fears, but I can remember a little bit thinking about that.
Yeah,
thinking,
you're going to fall asleep.
I don't know if I want to go to sleep. I'm going to stay here and stay awake.
Yeah. Make sure I stay
read my
awake.
comic book with a flashlight or something. 'Cause
Yeah.
I go to sleep. I might not wake up. I might just be like Uncle Bob there and die quietly in his sleep. And there was studies done in the 60s, going back way before the current,
Mhm.
the current dental sleep awareness has only began in the early 90s.
Mhm.
Now, we were doing that with our study group because we were involved with people who were at the top of their fields in orthodontics and ENTs and other things. So we were looking at these sort of, at that time, were fringe things. So sleep was a fringe thing. But we were doing tongue-tied release in the early 80s, and we were doing myofunctional therapy, and we were doing expansion of different types. So we were in that. I was in that group that was worldwide, but we're kind of pushing the envelope on these ideas. What could be done?
That's now common. A little bit
Yeah.
more. Yeah.
And because we were diagnosing all those things, that group was um, started this whole line of thinking, which I tend to drift off of because I'm from the South, so we have stories, and everything's about a story.
Yeah.
Was the CT scan? Well, that group was a lot of the members in that group, and we had some from internationally that came to our group. So they were looking at different things at different places. Well, there had been in Italy, developed a CT scan for dentistry only, specialty designed for dentistry.
And what year was that? Was that in the 80s?
That was in the mid 90s.
Okay.
Mid 90s when Dr. Tomasi in Verona, Italy, from the Tomasi wine family. Some people who are wine people would know this region and know that family. He was a physician and I think maybe an oral surgeon.
Okay.
As well. I don't remember what he did in Italy exactly. I don't remember, but he developed this cone beam, which was a different kind of a technology than the existing CT scans they use for medicine
In the U.S.
everywhere.
Everywhere. Okay.
And a CT scan is a scan method, and it's still true today in the medical CTs. A CT scan takes a series of slices.
Okay. Of the area you're looking
Like
at.
My son, when he was 7 or 8, had a puzzle we got him for Christmas or birthday or something, was a Darth Vader head. And it came in a box, like a puzzle in a box, but it was sheets of cardboard that were all black. And you stacked these sheets in a certain way, and when you got to the very top, you'd created this three-dimensional Darth Vader with little jagged things all over him. But that's what a CT scan is. Traditionally. So a CT scan would then create the same Darth Vader image in the computer. This is important. The computer was programmed to connect the edges of those dots.
Oh, I see.
So it was an enhanced image. You with me?
Yes.
It wasn't the actual image, it was the enhanced image.
Okay.
Because it was taking a series of slices and reconstructing them.
Okay.
But there were little pieces gone
on
the edge of the slices, right?
Yeah.
So what Dr. Tomasi did was develop a different technology that took 360 full volume views of the head with extremely low radiation, which was lower than the standard CT at the time.
Nice.
Yeah.
Yes.
So for the first time ever in dentistry, we had the possibility of seeing all these structures in 3 dimensions with less than 0.01 degree of distortion.
Wow.
Which meant what you were looking at in real time was exactly what was there.
And you were one of with the 6th group of gentlemen
we
brought it to the United States.
That's right. One of our members was from Italy, and he began to bring these cases to show at our study club. That's what we did, show the cases we treated. And that's exactly what it was. He's putting these images up, and I'm like, what is that? Never seen an image like that, Deuce. His name was Ivan Deuce. He was a gynecologist who became an orthodontist.
Wow. Okay.
Studying with our mentor. And
Full body.
He decided he was tired of that, and the economics of healthcare in Italy were lousy, and orthodontists could make more money and do better because they could do what they wanted to do. People paid them to do, not the healthcare system. So they were free to do the kind of treatment they thought was good.
Yeah.
So Yvonne was a member of our group, and he's showing us these cases. And I said, what is that? What kind of image is that, Yvonne? I've never seen that before. And he said, oh, well, that's a cone beam VCT. I'm like, what are you talking about? And now we're all like, what?
Yeah.
We never heard of this. So we start talking about it. So we talked about that meeting. Group of us got together, 6 of us, along with Dr. Gugino, our mentor, and Yvonne Deuce. And it took a year, but we convinced Dr. Tomasi to begin to import these in the United States.
Wow.
So we had to create, I wasn't part of the company, but I helped create the company. The instrument at that time in 2002 or 3 was $198,000 for this instrument, the most expensive dental thing you could even think of. So We actually built a separate center here in Seattle just for those images, so any dentist could refer a patient there and have these images available. And I taught courses locally on
Mhm.
how to do it and what we were seeing, what to look for. Because it was all new.
Yes.
Dentists weren't used to looking at these images.
Yes. And now we use them all the
Now
time.
that's all I use.
Yeah.
And I use that.
Yes.
That's all I use.
And would you explain too how, it seems like it's not always 100% accurate because the position of people's heads when people have CT scans done.
Right.
I remember learning that from you that, the way they have you in that machine, if it differs, it can close the airway, open the airway. That's why I liked when I came to you.
Yeah.
I knew you would give me the reading that was correct.
Yeah.
Because you have done this for so long.
It does change your diagnosis
Yeah.
when you don't get the patient postured properly or you don't take the image properly. It's not very, and of course the machines vary widely.
Mm-hmm.
So the more expensive machines, it's still true in this case, the more expensive the machine, the better image you're going to get and the larger image.
Yes.
So for the work that I do, the work that we do, we have to have the full image.
Full image, yes.
Yeah, we have to have from down to about C4 or 5 all the way to the top of the head and the back of the head, everything. Because we can't get cranial volumes, and cranial volumes relate to these volumes geometrically in human skulls, right? So we have to be able to see all that and use that in our calculations.
And that's why it's nice for people to come to you and get these results. It's not just about you're just some other person out there. You have seen and experienced a lot and taught a lot of people what you have.
48 years now.
Yes.
I've been treating craniofacial pain patients.
And how long have you been teaching other dentists and orthodontists how to do what you do?
Since probably the mid 80s.
Mm-hmm.
Mid 80s.
Okay.
I haven't done it consistently. I've always been ready to present it. I've presented at meetings and new research that I've done, findings that we've had.
Yeah.
Certainly for a few years there, the cone beam CT was one of my main topics when I traveled around the country for meetings and presentations. I was trying to educate dentists about cone beam CT technology. Now it's very common, but that also brings problems because patients should also know if the dentist takes a cone beam CT scan, what is the volume of that scan and who read and interpreted that scan.
Yes.
Now I'm really good at it because I've been doing it so long, but I'm not a maxillofacial radiologist.
Correct. Yeah.
So legally, dentists now are totally responsible for anything that exists in that image volume. Whether they look at it, whether they identify it or don't, if it's on that image,
they're responsible.
They're responsible for that. So a failure to diagnose those things is also a big problem. So we use consistently, even though as I said, I'm very experienced in reading those, but I'm not a maxillofacial radiologist. Yeah. So we have one that we use, and all of our CT scans go to him. Yeah. He does a very thorough and specific report that we have designed, and he's agreed to do these types of evaluations, which are not typical for dentistry either. It's more expanded, and that's all then verified by radiologists.
And legally, that's so important to do.
Legally, it's important. Absolutely, legally, it's important. In fact, there's no argument about it legally. Yeah. So dentists who are not doing that, and I know most of them don't, are not doing that. They're treading out there where angels tread.
And that's good for people to know that if they do have a CT scan done, it should be read and the results should come from a radiologist. And if not, just know that should happen.
And that doesn't matter whether it's a small area, like a lot of dentists have they have a less expensive CT scan, but it'll only image like this much area of the face.
And not the whole
volume. Yes. And not the airway and other things that you want to know about. Yeah. But they should always be read. If I had one taken, I would want, in medicine, there's never going to be an image taken on you that's not read by a radiologist. Never. Yeah. Yeah. No GP walks in and just takes an x-ray of you and goes, okay, that's what's wrong. Yeah. No, those are always read by radiologists. Yeah. And that will ultimately probably be forced upon dentists, not because that's what they want to do necessarily. They're too lazy or they don't know where to send it or whatever. They don't have a connection for that. Yeah. But they'll be forced to because there'll begin to be these legal actions.
Yes.
And I see them already. I see them now.
Well, and on airway,
failure to diagnose.
Yes,
see, it's still part of that picture.
Yes, and I know for me with Heavenly Smiles, I have some steps, and the fourth one is nighttime protection if people are destroying their teeth through clenching, grinding, maybe acid reflux, all that happens.
Right.
And I know you and I have discussed that, early on you were like, well, Andrew, I really don't like mouth guards because they can actually create problems.
Right.
And so for people who maybe wouldn't come to Seattle, or they're not in that much pain, but they need nighttime protection, what would you recommend? How would you speak to that issue?
Well, I think, yes, as Andrew said, I don't recommend night guards. And that's what they're usually known as. Night guards are made to theoretically protect people's teeth and jaws from overstress.
Yeah.
But they don't necessarily reduce the stress at all, or if they do, they reduce in some areas but not others. The goal would be to nullify any jaw function or dental stress.
Yes, with the muscles.
To nullify that.
Yeah.
So that means you have to do whatever you can to design an appliance, if you're going to make one, it has to be specifically designed to meet the requirements of minimal muscle activity, ideal jaw joint relationships and function.
Yes.
As well as not interfering with any dental relationships.
Yeah.
So the typical night guards made day to day in offices all over. They take an upper and lower impression of your teeth. They send that to the laboratory. The laboratory makes a standardized. They say, oh, it's custom fitted. Well, of course, it's custom fitted to the impressions of your teeth.
Yes.
But it's not custom fitted to jaw joint function, muscle ideal function, swallow function.
Yes.
All those things are not part of that formula. Then they put that in your mouth. They can be uppers or lowers. I would always recommend a lower, never an upper.
Yeah.
Never,
like the lower flat, just so
if you're going to have a night guard made, it needs to be,
if you can.
Yeah, and probably quite thin. This is the other problem with night guards made standardly, is that typically they're way thicker than the patient's physiologic resting space between their teeth. It's normally when we relax, everything's working right. We have ideally a space of about 1 to 2 millimeters between our relaxed and first tooth contact where the teeth fit.
Mm-hmm. Yeah.
Usually the patient relaxes their jaw and they close, all their teeth don't come together.
It's just a little bit of space.
That's the first thing. That's the first sign that they got a bite problem.
Oh.
They relax their jaws, take a few deep breaths, go to their Zen place, just let their jaw relax, and then they gently elevate their lower jaw to the first tooth contact. So frequently that's somewhere in the front or in the corners.
And mine does, because he's fixed my my clenching grinding, and it did. Yeah, it's right there at the front.
Yeah. Say it's common. It's a common problem, and that's because of the maxillary deficiency. I mean, you see, it all goes together.
Yeah.
So that again goes back to diagnosis. These appliances that are made sort of bulk appliances, if you will, in the laboratories, even though they're custom made to fit the teeth, they're not custom made to fit these other things. The average thickness of these appliances by manufacturers, by the manufacturer of the plastic component, plastic material. There are many materials out there that can be used, but the one that's used significantly and commonly, the manufacturer recommends at least a 5 millimeter thickness.
Oh, wow. Yeah.
So
that impinges on.
We've looked at in studies, we've looked at several thousands of patients and documented the average resting space between the upper and lower teeth.
Yeah.
And thousands of patients have actually been objectively measured to a resting muscle position.
Yes.
And that works out to about 2.5 millimeters.
Wow.
Now, for treatment, the ideal goal for treatment, and where we seem to get the best resolution of many of these symptoms, is if that space, among other criteria, is between 1 and 2 millimeters.
So thin, lower,
very thin,
flat. Yeah.
But if it's thin, you're gonna break the appliance, because you're still gonna be grinding and bruxing on the appliance.
Right. Unless they come and see you, because that's what you help me with.
Somebody that does, what I
what you do to get
they're
them
they're gonna break the appliance. Then they're gonna go back to the dentist. Oh, I just wore this for 3 months. I paid $600, $700, $900,000 for this, and it's already broken. Now they got to replace it. So the dentist goes back to the manufacturer and says, "Oh, you need to replace this. I'm not paying for it.
Make it thicker.
Patient's not paying for it. And that's what do the labs do. Make
Make it
it
thicker.
It's got to be stronger. The more plastic, thicker,
Yeah.
stronger. So that's the criteria.
That makes sense.
It's not based on any science
Mhm.
whatsoever.
Mhm.
It's just based on a mechanical idea. Well, we want teeth mostly to touch, so it's got to be
Yeah.
kind of flat. If there are bumps and lumps, then there's going to be problems with that because we don't know how to fix that. So it's ideal. But
So
yeah,
it would be
appliances
best.
can be made, but they get expensive.
And
Yeah,
they can come to you if they're breaking appliances or getting pain, neck pain, headaches from appliances because they're trying to protect their teeth. They can come to you and you can put them on the machine and get them into something that does work, but it also is not stressing
For
the cranial
vast
muscles.
majority, well over 90% of patients.
Mhm.
Yeah,
Yeah. And
that's
that's
possible.
what I think for
It's
me.
not a pipe dream, in other
Yeah.
words.
And it's not that expensive really to come to you.
And then when you think about it, I get patients that they're breaking their teeth off.
Yeah.
Their dentist refer them because they're breaking their teeth off.
Yeah.
And then the dentist crowns the tooth and they break the crown off.
Yes.
Or they break another crown off on the other side because now you put this other tooth
It's
in.
real expensive.
It starts getting, and now I'm breaking teeth off. So
Yes.
actually many patients come in that way.
Yeah.
And you're like, well, I don't understand this. My
Yeah.
teeth are breaking here and there. Well, you've got this bite problem. You always had it.
Yeah.
And your dentist attempted to make a crown and did the best they could, but it created a different kind of interference in the bite,
Yes.
perhaps.
And if people can get in protection and have this not be hurting, that's such a win-win. And the cost of
best
that,
of all worlds
yeah.
in the end, yeah.
Yes, and that's
2 patients right now that had all their teeth ground
oh
because they were wearing their teeth off. So the dentist crowned all their teeth, but now they're breaking all the crowns that they put in.
yes
So the dentist, frustratingly, has referred them
to
to
you.
me to say, what can be done about this? I mean,
Yeah.
get all these crowns done. Of course, the patient's not happy. They paid what?
Thousands of dollars,
$60,000, $70,000, $80,000
Yeah.
to have that done, and
Yeah.
they thought it was going to be lifetime fixed, and now they got a worse problem now because now they're not breaking their actual teeth off yet.
It's kind of like a car. If you put new tires on it, but it's out of balance, you're just gonna
It's out of
be a
alignment.
mess.
Your
Yes.
tires are going to last about 25% of what they should.
And that's what I think about you and what I had done is that, I was out of balance and
Right.
I just wanted to be put in balance. And it is amazing to feel the way I walk, the way my spine is, just this head position being correct and my jaw being correct. It's priceless. I tell you all the time, I would have paid you 3 times what I paid
We
you.
appreciate that.
because
I wish I knew that
Yeah.
then.
Me too. I still probably would have done it. But, honestly, the treatments I looked at were, almost $100,000 and they wanted to do crowns on all teeth. And when I saw what you were doing and then I met with you and then you sent me to Texas and Dr. Zoggy was talking at your conference, who was teaching everyone in my state tongue tie releases. He's a great, ear, nose, throat specialist, sleep apnea, specialist. And to see him at your conference, and I think you're very humble, and I want everyone to know really who you are and that your heart is to help people. You love, I think you're at a point in life where you could be fishing with your brother and hunting, and yet you love seeing, when I saw people come in tears and you were able to get them out of pain and no one has been able to get them out of pain, that's who you are. And you have such a big heart. And like I said, your treatment for me was like almost nothing compared to what other people wanted. And yet I always felt in my gut that what you were saying made sense. And you had reason and scientific data and experience behind what you were saying. You weren't just saying, hey, I'm just doing this and just follow it.
Right.
You very much like, think about what people are asking you to do and why. And so I just think if people even came to Seattle and had the workup done and just hear what you have to say, especially if you're in pain, especially if you're throwing out your appliance at night and nothing's working and you're destroying your teeth and you're paying thousands for implants, it's like, whoa, why don't we do a timeout here and see if we can get things to relax? And that's what I love. Like when you saw me, you're like, your muscles are actually relaxed. We just got to move some teeth and give you some more room on the top. So I appreciate you so much. And
You're more than welcome. I appreciate you having the confidence in us.
Oh, I
to
do.
Go to all the trouble it takes to come here.
Yeah, well, it's nothing. I tell people it's like having asthma, and every time I would come see you, it's like I can breathe a little deeper. Because what you do is you open up things. It's like you said my face was really tight, and you're relaxing everything, and my muscles are just finding that home that they've always wanted to be in. So for me, it was wonderful. And I share with everyone, all the patients I see know about Dr. Simmons, because I tell them, please, at least, come and just do an exam, or so great to see kids. I've heard you'll see kids for free, at a certain age, because your heart is to help and get them guided into the right treatment. And so I enjoy every day I've spent with him. I always learn so much. He's invited me to some conferences where he's taught orthodontists, and I get to just sit there and I just love to hear it all. I'm not smart like them, and I can't retain it all, but just to hear the hope.
It's not about it being smart, it's a matter of being persistent.
Yes.
That's what I've done. I've always stayed in the fight and always looking at better ways to do.
Yes.
But as you said, it's got to make sense.
Yes. Logically.
It can't be a pipe dream.
Yes.
Or magic pill. There is no such thing.
And if someone tells you we just do it, that's just how we do it, and they don't explain to you why, that would be a red flag for me.
Yeah.
Because I want to know and understand what's going on. And so so we hit on, for me, I was a clincher grinder, so people understand balancing this out, which is what you do. And you do that in different ways. It's not always braces. It could be a lower appliance that you put on someone and you see them once a month, or like you saw me every 6 weeks or so.
Right.
Every case is different,
Yeah,
how you
different.
treat, but you can help people. And the sleep appliance, that's a 3 appointment kind of a thing. If people,
Typically.
yeah. And you can
Follow up if they need it. But
yes.
very few people do.
Yes. And I know for our family, like the sleep appliance he has, I just can't wait to have my son get started in that. So, because I want him to be balanced. And you seeing my son was a perfect example. You could look at my son and boy, it could be cha-ching, cha-ching. But you were like, hey, you're fine. You're not in pain. You obviously have sleep apnea. So and he's 22 years old, that's a really easy, inexpensive fix for his situation that somebody could recommend spending jaw surgery even.
Oh,
Because his upper's a little bit in. And
saw one of those yesterday. And it didn't work.
yes. And you did explain that now the research out with jaw surgery is that after 10 years, the data is saying
Significant
it's not healing too. The bone's not right.
Probably relapse significantly.
Yeah.
Because they can't move the muscles all around.
Yes. And how long ago did you stop doing jaw surgery and actually with what you do for patients, directing that way? Has it been 20 years?
It's been probably over 20 years now.
Yeah.
Since I've seen very, very few people to surgery now.
And you've seen people, I got to see your patients come in here where they did do surgery and had you treat them, and they're so thankful.
Yeah, they're better after that. Yeah.
And who wants jaw surgery? It's a terrible surgery. I mean, people swell up.
Once it's done, it's done.
Yeah.
You hope for the best, and you hope for a good result, but there's no way to test.
Yeah.
There's no way to test the retention of that result or whether it even worked.
Yeah.
You just do the surgery with an optimistic
Yeah.
idea that it is going to help you.
And you see people who have the surgery and they're in pain, though it didn't fix it, right? So they're seeing you.
Not only didn't correct their sleep apnea, but now they have other pain and jaw function issues. True.
And I was taught in school 30 years ago or plus that TMJ, like you didn't mess with it. People could have clicking, popping, but it was like opening up Pandora's box. It was like, it better be really bad to treat because you can make it worse. Like I was taught that way back then.
Yeah, the patient's got to be insistently on to you about what can be done, because that was the standard. Well, because they really didn't know what to do. So
unlike you,
it's not good to do things to people and you don't know what to do. What are you going to do for them?
Yes.
So a lot of these people were thought to be just untreatable.
Yeah.
I got a lot of that from my colleagues in the early years.
Mm-hmm.
They would say, well, I never even heard of anybody doing this. Why do you treat them? They're all crazy, aren't they? I mean, that's what I heard. That's what I was told in dental school.
Oh, these people are?
Yeah, these people that come, they're all crazy people.
Oh, my goodness.
So, we got a few people that are difficult to manage, but and once a year or so, we get somebody that's probably borderline certifiable.
Yeah.
But for the most part, they've been driven crazy by their problem.
And their pain.
They can't work. They can't have social life. They have chronic pain all the time, and they've gone to 20 doctors and different kinds, and they've all tried this or that, or just told them there's nothing to be done, or there's nothing wrong with them.
Yeah.
They just have a psychological problem.
That's so sad. Yeah.
But they have a psychological problem because they're in pain 24 hours a day.
Exactly.
And stressful, and their life is kind of ruined.
And I
So-
had a patient who told me their friend committed suicide because the ringing in the ear made them go crazy. They couldn't take it anymore. And when I found out when you said, "Oh, I see people with that," and you know what I do does it can help people if it's something I can treat. That was huge because I hear when I tell people now, they'll tell me my friends and my family, "Oh, I have ringing in the ear all the time. Oh, I have vertigo." I'm like,
Yeah.
"What?
Well,
Did
do you
you
like
just live
it?
it?"
If you do you like it,
They don't know what to do with it.
because they probably already mentioned it. So they probably already had their
Yeah.
ears checked and
They've been
they
told.
can't find anything.
Yeah. Yeah. So,
Yeah. It's
and you
really-
do have a friend that also does. Is he in Tennessee? The gentleman that you guys have worked together, and he was at
He's
the
in
conference.
Tennessee. He's at the
Steve.
he's at the point where I am in his practice, but he differently from me. He's going to be retiring.
Yeah.
I'm not planning on it, and I have a younger colleague who's part of our team.
Uh-huh.
He's in Little Rock, Arkansas,
Okay.
and he does more comprehensively what I do.
Okay. So there
We've
are
worked together and
other people.
lectured together for a long time, learned
Mhm.
from one another, and
Yeah.
so he actually built an office in Little Rock, especially to do what I do here. So our office doesn't look like a
Yeah.
typical dental office.
Yeah.
We're not set up that way.
Well, and I like people to know to call you and get a hold of you and then go from there.
Yeah.
They're down in Little Rock, great. If they're here or can travel. And I know you moved from Tennessee to Seattle years
Right.
ago so people could fly in to Seattle easily.
So people could get to me.
Yeah.
I was in East Tennessee and was successful locally, but it wasn't what I wanted to do primarily. I wanted a different kind of practice. So
Because you have people come from New York, you have people probably
come from
international.
yeah,
Yeah.
a lot of international patients.
Yeah. And I know that you've done classes or gone over to Germany and different places international
Yes.
too, right? It's
Yes.
not just I guess I like to say that because I think people they don't know where to go and they don't know really who's an expert. And I would say you are in this field, in this area, you are the guy to go to.
Yeah.
If they want to do something else, that's fine. But how many people come to you and then go someplace else and they end up coming back to you because it didn't work?
There's a bit of those.
Yeah,
But
a few stories.
we're just here. We're available. I can't be in every community. I know we have a lot of patients from the Boise area, from
Yeah.
Idaho, and I've been asked by lots of people, why don't you come and start and set up a satellite practice in Boise?
Yeah.
I'm like, what?
No, they have to
No,
come
that's
to me.
it's crazy. I can't, I can't do that. I had a satellite office for many years, as you know, over in
Mhm.
Bellevue, which
Mhm.
is, 20 minutes away, but it's a entirely different community. We're across the lake in Seattle, so
Yeah.
Bellevue had no one, so I went over there years ago, and I was going to go over there for 4 or 5 years. I thought, and ended up being there 16 years.
Wow.
So, but I just can't. There's only so many pieces of me, and I can't
Mhm.
spread it out that thin anymore. So
Yeah, and one thing I do see with patients, and you asked me with my clinching and grinding, you're like, were you in an accident? And I said no. You said, well, most likely I could probably help you, because because I have friends who've had neck surgeries and all this stuff, right? And there are times where there's a lot involved, but if they can come to you and be evaluated, and you can at least direct them
right,
where maybe it would be best.
yeah, we do. We see a lot of people who've been in accidents, especially automobile
Like
accidents, but
whiplash.
industrial accidents. All these would have been whiplash type accidents or injuries where they received some direct blow even to the jaw.
Yeah.
So we do see a lot of those patients, and in the cases where it's a cervical whiplash, people are being treated by, again, apparently a lot of different doctors would be involved in their case. It becomes, again, a sort of a process of trying to find somebody who can do something.
Yes.
And we in our diagnostic protocol, we have a way to sort of separate out the patients who may be having a neck problem, and the neck problem is actually secondary to the bite problem.
Okay.
They don't have a primary neck problem.
Okay. So they fix the bite, helps the neck.
Right.
In
And then
some
we see,
cases.
and you see those patients where, they have both,
Mm-hmm.
but we can't direct the neck exactly. So we have to treat this, and then
They have to
they
go
have
see
to be
someone.
helping us,
Yeah.
whether it's a orthopedic, physical therapy, osteopath, chiropractors, whatever,
Yeah.
need to be helping us with the neck and solve that problem. So it's also really important in any patient to be able to discern, well, where is the problem? As I said
Yeah.
before, where's the problem coming from?
Yes.
If you're busy treating a neck problem and what's causing the neck
It's
problem is
here.
this,
Yeah.
and you can solve this and see the neck
Yeah.
problem go away, but they're going to
Mhm.
spend 5 years and $100,000 on their neck
Yeah.
with very little improvement.
Yeah. Changing your mouth can change your life.
Absolutely.
It can.
But you need to be able to figure out which one of those is actually happening.
Yes.
And it's actually pretty easy to do, but you just have to know how to do that.
Have to know how to do that. Yes. Well, I thank you so much for
You're
who you are.
You're so welcome. I appreciate your interest and wanting to spread the word to other people. That's the only way this can happen.
Yes. And that truly is my heart. And he took his time out of this day to give to me. I'm just a nobody, really, a hygienist from Idaho who just wants to help people. And truly, he is a huge part of that equation. I wish everybody, it's like, I wish everyone would have a sleep test done. Wish everybody who has any kind of teeth clenching, grinding, sleep apnea just comes to you and have a workup done, and just know, have your expertise, I guess, is priceless. And even what you charge is nothing in that big picture of having data that you will always have going forward.
Right.
No matter if it's 10 years or whatever, you can look back at what you did for somebody and the workup and, like you say, the time you take.
Evaluate the changes even over time.
Yes. I mean, 3 hours or more that you spend on a case.
Right.
For what we pay is like nothing to have. So I just want to encourage all those people who watch my videos. Again, he's a huge part of my heart as he's helped the world in so many ways. I hope in the rest of my career, I can help people on the internet in a bigger way to understand that there are people that can help and who love to help too.
Yes. Thank you so much.
Yes, you're welcome.
Appreciate it.
Thank you for the time.
It's been a pleasure.
Thank you.
Appreciate it.
Thank you, everyone.